Barbara, you can unmute whenever you want.
I'm unmuted. Hi, everybody.
Hi, everyone. Just going to start my video.
Are more people signing in?
Yes, there are.
Okay, we'll wait a few minutes.
And you have one of the doctors who's going to be speaking.
Dr. Davis?
And hi, Max. I'm Rebecca. Welcome to the team. We're really looking forward to getting to know you.
Oh, it's Max. How are you, Max?
There we go. Hi, thank you very much.
Max, were you the one that helped us with the Parks Committee? Didn't you look for open space at one point, or is it a different Max?
When was that?
A couple of years ago. I don't know.
No.
It wasn't you? Okay, great.
And for all those tuning in, Max is our new assistant district manager, and we're really happy to have him.
Thank you.
More people are signing in, Will.
Yeah, still coming.
And who is here? Is Dr. Davis here?
Yes.
Yeah, I'm here. Can you hear me?
Yes, I can. Oh, good. Thank you. And Dr. McDougall, is she here?
Not yet.
Not yet. Okay. She will be.
Did you get the slides, Rebecca and Barbara?
Yes, and Will, you got it also. The slides are great.
Perfect.
I did. And if you would like to share your screen, you can, but otherwise I can put it up.
Oh, yeah, you can put it up. I'll just say next slide, please.
Okay.
We'll give it another 5 minutes or so. It's just 6:30 now. And Alita's not on yet, is she?
She just joined.
She did great, Alita.
And Anna Garcia is here.
Great.
Wow.
Anna, is Dr. McDougall coming soon? Do you know? Is Anna unmuted, Will?
No, she's not, but she is now. She can. Anna. Oh, you just muted yourself back. Try that again.
Hi. Yes, I'm just checking on.
I see her.
Oh, okay. You see Dr. Davis or Dr. McDougall or Dr. Riley? Is that what you were saying?
Dr. McDougall.
Both. Yeah.
Perfect.
So let's give it another 3. Are more people signing in at this point? Will?
Oh, let me check.
Thank you.
Yeah, there's a few folks who have signed in recently that have not popped up yet in the. I do not see anybody else signing in right now. So if you guys are ready.
I'll get started then. So welcome everybody to Community Board 8. We are the Health Senior Social Services Committee. I'm Barbara Rutter and my co-chair is Rebecca Danagor. And Lita Camp is the chair of our community board. Thank you for being so helpful and supportive as always. We are living through very unprecedented times. This pandemic has brought to the forefront the many dangers that we all of us are facing. But we've also realized that how this virus has affected the disadvantaged especially hard. And we all are aware, especially those of us that stayed in the city, how interrelated and interdependent we all are. How can we forget how dependent we were on those that came to help us, to help feed us, to deliver our goods, and to make our city a more livable and workable city. Our committee is the Health Committee, and therefore we want to address equity in our healthcare system. Equitable healthcare for all is not only a moral issue, but I think we all realize that our neighbor's health means our health also. We are committed as a committee to address some of these issues. We're presenting, this is the first of 3 different meetings that we will present to address what is wrong with our healthcare system. How is the healthcare changing because what we have learned, and what do we still need to do? We are so pleased and honored to have 2 outstanding doctors, one from the public hospital and one from our private hospital, to help us address some of these issues. Our first presenter is Dr. Nicola Davis, who is Vice President and Chief Population Health Officer for the New York City Health and Hospitals. H&H is the largest public care hospital in the United States. And please, Dr. Davis, you will tell us what a Chief Population Officer actually is. Dr. Aja McDougall is the Director of Women's Health Practice and Community Health at New York Presbyterian Hospital, where she is committed to provide the best care for all of her patients. And she is now with Anna Garcia. We're so pleased to have Anna, who is the Director of Government and Community Affairs. Is that right, Anna? I think that's correct. Am I right in that? And if she wants to say a few words, maybe at one point she will be able to do so. But before we begin, Will Brightbill, who's our district manager and who manages to magically put these Zoom meetings together seamlessly, he will give us some of the rules. And please, we will hold our questions until both presenters. Thank you. Will?
Hi, everyone. Yeah, thank you, Barbara. Thank you, Rebecca. I will be very brief. Just if it is your first time at one of our Community Board 8 Zoom meetings, we do have everybody muted so that you don't accidentally interrupt any of the presenters today. The way that you'll engage the presenters and engage the co-chairs whenever they call on you or whenever the time comes up is that you'll use the participants button at the bottom of your screen to find the raise hand button. So you'll open up the participants box. So if you're looking at the bottom of your screen, it looks like 2 little people standing next to each other with right now the number 28 next to it. That number will change over the course of the meeting. But once you click on that button, a box will open up on your screen and you'll see in that box a raise hand button. The co-chairs will see your name go up on the participants list and they'll be able to call on you in order that you raise your hand. They may ask for you to be unmuted, and we may need you to unmute yourself at the bottom of your screen whenever that time comes up. You'll see a little prompt that pops up on your screen. So if you're called on by the co-chairs, look for that too, as it'll speed up the course of the meeting. If you have any questions about the way Zoom works and about the way the meeting is run, you can always chat me in the chat box, Will Brightbill. Otherwise, I'll hand it back over to our co-chairs and look forward to the great meeting.
Dr. Davis?
Great. Can you hear me?
Yep, thank you.
Perfect. Will you be sharing the slides?
Yes. Let me go ahead and get them up if you're ready.
Yep, I'm all set.
All right.
Great. Thank you. So thank you very much for this invitation tonight. I'm really excited to talk to all of you. And I'll just share a few slides that'll just go through how COVID has highlighted healthcare inequity. And hopefully we'll be able to have a rich discussion following both mine and my co-presenters' presentations this evening. Next slide, please, Will.
There you go.
So I'll just start just to level set so we all know what we're talking about when we talk about health equity. So health equity is really very simply put, it's when everyone has the opportunity to be as healthy as possible. The opposite, healthcare inequity, are really the avoidable differences that are unjust or unfair. And it's a situation where everyone does not have the opportunity to be as healthy as possible. Next slide, please. I think what's really important to understand is the difference between equality versus equity. And when we're thinking about equality, equality speaks to the same, everyone having the same thing. And as you can see from the top half of this panel, everyone indeed has the same exact bicycle. So theoretically, they should be able to get from point A to point B because you've given them the same tool. However, we realize that it's not really the right fit for many of the participants here, right? So the first person is too short, their feet can't reach the pedals, so they're not going to be able to get from point A to point B. The second person, well, they have the right size bicycle, so they should be able to get to where they're going. The third person, you can see they're too tall. So when they're on the bicycle, they may be able to get from point A to point B, but you can imagine that that might be a slower journey than the person in front of them. And the fourth person is in a wheelchair. So the bicycle is of absolutely no utility for her. So they all have the same equal tool, but they're starting from different levels of opportunity, and they're not able to use the same tool. Now, when you see equity, what will happen is to get from point A to point B, they will have the right tool that fits them. So the smaller person has a smaller bicycle. The person that's in a wheelchair has a hand cycle. And so now they have the same opportunity to get from point A to point B. So I just say this so that we can understand the difference when we're talking about equality as opposed to equity. Next slide, please. And in this slide, we're emphasizing the same thing, which is the difference between equality and equity. And so you can see that to be able to look over the fence, you know, in the second panel, you need the shortest person needs more blocks. But the reality of it is that there's some people that have many, many blocks, and they have a significant amount of advantage, while there are others that are really disadvantaged. And so we have the differences that we can see between equality, equity, but then we have the reality of what we're seeing daily. Next slide, please. So to drive this home a bit more, as a physician, I'm going to give you an example of a patient. And this is just going to give you an example of how we see healthcare inequity. And this isn't a real patient, it's not a real story, but it's very similar to what we see. And so you can think of it, for me, as a culmination of many different people that I see. So Ms. J is a 42-year-old woman who lives in the Bronx. She's had diabetes for 5 years. She has a primary care doctor that she sees regularly, but she has had difficulty controlling her diabetes. She's a single mom with 2 children, ages 11 and 8, and she works part-time as a cashier at a C-Town and part-time as a home health attendant. Sometimes she has to leave her children alone with her neighbors who check in on her children. Next slide, please. So, next slide, please, Will. Great. So what happens to Ms. J during COVID-19? Well, first of all, she lives in the borough with the highest rate of COVID-19. So you can see that when you look at the number of cases, and this is data from the Department of Health, the Bronx has the highest rates of COVID-19 as compared to the other boroughs. Ms. J also is an essential worker. Remember, she works at the C-Town, and so she works at a supermarket, and she's also a home attendant. So she's unable to work from home. She is likely using public transportation. She has diabetes, so she's at high risk for getting COVID, and she is at high risk for having bad outcomes if she gets COVID. Her children are also at home, so what happens when she has to go to work? Is she able to go to work if she has an 11 and an 8-year-old that are at home? And what happens to her children now that they're also in a remote learning environment? Who's there to support them? So you can see where there are many instances of healthcare inequity for Ms. J. Next slide, please. So why are we seeing some of these racial and ethnic inequities with COVID-19? Many of our patients, they have higher exposure. They're essential workers. They may live in crowded conditions or multi-generational households. They have less ability to telecommute. They may have higher rates of underlying health problems like diabetes, hypertension, and obesity. These all increase the risk of COVID-19. And they also have structural and environmental factors such as access to care, discrimination, and racism. Next slide, please. But there are also inequities and disparities that you can see in addition to by race or ethnicity. You can also see inequities as related to income or gender. You might also see it related to where people live versus a rural environment versus an urban environment. You can see inequities related to sexual orientation as well as disability. Next slide, please. Now I'm going to just talk a little bit about how our public health system addresses health inequity. Next slide, please. So at New York City Health and Hospitals, we are committed to equity, and as you know, we are in the world's most diverse city. The mission of our hospital system is to provide quality care with dignity and compassion, regardless of race, ethnicity, gender, national origin, religion, sexual identity and orientation, or ability to pay. Next slide, please. So we are the largest public healthcare system in the United States, and we provide care to over 1 million New Yorkers each year. And that's done in our 11 hospitals. We also have over 70 community centers. We have one long-term acute care hospital and 5 skilled nursing facilities. We employ over 40,000 employees, and we also have the Correctional Health Service. Next slide, please. When we look at the demographics of the patients that we take care of, more than 4 in 10 of our patients were born outside of the United States. And when we look at the sources of our foreign-born patients, they're coming from the DR, from Mexico, lots of the Caribbean, also from Bangladesh, and from Colombia and China. We use interpretation services very often at Health and Hospitals. Over 13 million minutes of interpretation is done in 200 languages in the last year. And I can definitely say that there are days when I would see patients and I would be going from interpreter from language to language just because of the diversity of our population. And so that's pretty incredible to be able to take care of such diverse patients. Next slide, please. And one of the things that we really work hard to do is to address the social determinants of health. And this is part of what we do in our Office of Population Health. This is one of our teams that we focus on. And so what are the social determinants of health? Well, these are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of their daily life. These forces and systems include economic policies and systems, developmental agendas, social norms, social policies, and political systems. Next slide, please. And when we think about what these social determinants are, we know that there are upstream factors that are driving both health and inequity, and these are the social determinants. So if you look at the left half of this slide, what you'll see is that we have social inequities, we have institutional inequities. These lead to various living conditions, and these will lead to the different risk behaviors that patients may encounter. Eventually, it might lead to disease and injury and mortality. Now, downstream, far on the right, this is where health systems primarily work. However, what we can do in this space is limited. And to really have an impact, we need to get more upstream, and this is what we try to do when we take care of our patients. And so they asked for me to talk about what a chief pop health officer does, and this is part of what we do, is think about the entire patient, the entire population of patients that we take care of, and how do we get high enough upstream so that we can really have impact on our outcomes. So we recognize that helping our patients get and stay healthy requires a lot more than just the healthcare aspect of things. And one of the things that our team does is we really try to prioritize the social needs of our patients, and we try to prioritize it at the same level that we prioritize their physical health as well as their behavioral health needs. Next slide, please. And just to give you a couple of examples as to how we do this, so one of the things that we do is proactive screening of our patients for social needs. And once we've identified needs, we really try to meet these needs. And many of these needs are their legal needs, food, housing, and income. Specifically during COVID, some of the things that we did were to have active outreach to patients that were discharged from the hospital with a diagnosis of COVID, and we outreach to them to assess their social needs. By being proactive and outreaching to these patients, we were able to reach about 6,500 patients who were discharged with a diagnosis of COVID. Of those, we were able to identify food needs, food insecurity in about 25% of them, and to get them that food assistance. We were also able to through grant funding and through some partnerships, be able to provide cash assistance to some of our patients who really had extreme economic hardship. And we were able to provide $1,000 to some of our patients who had such hardship. Next slide, please. For some of our patients with chronic diseases, we really had to work to try to provide them the best care possible in these challenging circumstances. So we did a lot of pivoting from in-clinic visits to televisits. We did a lot of proactive outreach to our patients to identify their needs as well. We purchased and distributed blood pressure monitors so that our uninsured patients with hypertension were able to monitor their blood pressure at home. And we really worked at trying to expand some services such as peer support via telephone to help our patients manage their diabetes more effectively. Next slide, please. So as we know, during the midst of the COVID pandemic, we experienced a lot of unrest and protests as a result of the killings of George Floyd, Breonna Taylor, and Rayshard Brooks. This all happened at the same time, and it really helped to emphasize the dual pandemics that we were seeing in America. Not only were we seeing the pandemic that was due to COVID and recognizing the disparity that was happening in terms of outcomes amongst Black and Brown patients, but we're also seeing that pandemic of police violence and worse outcomes that were happening, particularly among Black men. Next slide, please. And at New York City Health and Hospitals, we recognized that it was really, the slide before that, sorry. One more after. Oh, okay. Well, maybe we missed one. But at New York City Health and Hospitals, we really recognize the importance of standing with our community in terms of really speaking out and standing in solidarity along with our patients who were out protesting, many of them, but really recognizing that this was a time for us to stand firm and in solidarity with all of what was happening and to speak out against these health inequities that we were witnessing. And how we do this, we've really established our Equity and Access Council is one thing that we established after this was all happening, and really taking the time to listen to our staff and to think about how we move forward at this time, honoring all of what has happened, but really thinking about how we move forward to help our patients to have the best outcomes possible. One of the things that we do, we really aim to provide culturally responsive care independent of where patients are coming from, really providing that care that respects and responds to their health beliefs, their values, their behaviors, and the languages of our diverse patient population. At the end of the day, it really is treating patients how we would like to be treated ourselves, showing that respect, listening to them, honoring where they are, and really doing our best to recognize all of the challenges that they may be having and taking the best care of them that we can in the space that they are and with the challenges that they may personally be experiencing. And I think I'll end there and save time for questions later.
Thank you.
Thank you very much.
Thank you.
And then Dr. McDougall.
Hi, good evening again. I believe we had a little technical difficulty, so I'm going to speak extemporaneously. But first, I just wanted to acknowledge that actually the chair of our department, Dr. Laura Riley, has been able to jump on in her busy schedule, juggling a number of different things. So I just wanted to, if she wanted to just have a chance to say hello, and we'll talk more about Cohen Hospital as well as the Women's Health Clinic in the Hemsley Tower 5 to describe some of the community engagement that we participate in the services that we provide. Dr. Riley, would you like to say a few things?
Will you unmute her?
I don't see Dr. Riley. What does their name appear as?
I see her. Her picture is there.
Can she wave at me or raise her hand to the?
Could it be
oh,
the 019?
I think I found her. LAR.
Oh no.
You should be unmuted.
Sorry. Okay, I'm unmuted now. Okay, awesome. Hi, good evening, everybody. I'm so sorry to be hopping in late and then someone just called me at the same time. This is the problem with Zoom, is you can do multiple. So thank you for to join. I am the chair at Weill Cornell Medicine Department of OBGYN, and I actually have been here for about 18 months. And one of the main goals I had when I came here was to start to do a much better job with maternal mortality, recognizing the horrible racial and ethnic disparities in maternal mortality that exist in New York and actually across the world, but the US particularly. And so it's been great to work with many, many partners in New York City. And I'm actually on the Maternal Mortality Review Committee, which has been an eye-opener for me because I'm actually a Bostonian. So sort of this whole New York thing and how big you guys are and how complex it is, and it has been a learning experience. And I know that there's lots more to do, but it's been very helpful in sort of setting the goals that I have from my own department. One of which was to make sure that at the very least for our patients in the Women's Health Clinic, that we have a leader who is dedicated to community health as opposed to someone who's just there feeling stuck. And that was one of the very first changes I needed to make, because I think, as many of you will recognize, your ability to make meaningful change, I think, for both staff as well as for patients, really has a lot to do with who the leader is and how much dedication and investment that they have. So I'll turn it over to Aja. I'm actually also a high-risk obstetrician, and so this is yet another reason that I am completely dedicated to making sure that we make a change in terms of maternal mortality.
Thank you. Aja? Will, is she muted?
Yes, but she can unmute.
Okay, I'm sorry, it wasn't letting me unmute for there for a moment there. Thank you, Dr. Riley. And Dr. Davis, so nice to meet you as well virtually and hear about all the great things with health and hospitals. I am a native New Yorker, just a little bit about myself. I'm a native of the outer boroughs, so I'm from Queens, born and raised, a product of New York City public school education, and am so proud to have returned after living out of state for quite a bit and moving back to New York, but in Long Island, Suffolk County, a very different feel, and really coming back home to, participate here in Will Cornell as a member of community health. So, again, with Dr. Riley and Dr. Davis, kind of being aligned with the same goals of advocating for patients who have been underserved, and being able to really take advantage of a private institution, a institution that is well known and has many accreditations just this year. So, and now with a revived goal towards healthcare equity, I think is a perfect opportunity for us to reach out to various communities, especially one that's home to our institution, to tell you about what opportunities we have for you to be involved and what services we provide for our patients. So I think my slides did not get through, so I'm going to be just speaking a bit extemporaneously, so bear with me a bit. The clinic where I currently am working is called the Hemsley Tower 5. We endearingly refer to it as the HT5 clinic on the Cornell campus, and we have a number of services that we provide. Our providers are a mixture of medical doctors. We have training resident physicians, as well as medical student education. So this is really where the OBGYN practice, where our residents learn OBGYN and where they get all of their experience for both the outpatient and learn about both how to care for pregnant women, how to care for women who need GYN surgical needs. And we, take care of patients from pediatrics to geriatrics. So we have a full gamut of care that we provide. We have nurse practitioners, registered nurses, social workers as well. And we also work very closely with our in-house emergency care services as well. One of the great things about this facility is that we recently had the designation of the New York State Patient-Centered Medical Home. We renewed that designation for another 3 years and originally got it in 2014. What does that mean is that we have 3 aims: better health, lower health cost, and better patient experience. And we know that this year, especially under the leadership with Dr. Riley, that patient experience has been one of our main aims to make sure that there is an equal experience while we're giving equitable healthcare. In order to get this designation, a facility must achieve 40 core criteria, which are governed by the New York State. And in addition, we are Article 28 space. So what this means to us is that we can provide government insured patients with who are covered by both Medicaid and Medicare services in our facility. Our patients come from all 5 boroughs, including New Jersey and Westchester. And about 80% of our patients are from outside of the Upper East Side. So they've traveled from far, sometimes an hour and a half or more, to receive the care that we can provide before at Will Cornell and New York Presbyterian. So that's something to take into consideration when we are thinking about healthcare equity, is that patients are coming to our, the Upper East Side from outside because of the idea that they will be getting care that they perceive as high level care that and living up to the expectation. We provide government insured patients, charity care, uninsured and self-pay, patients on a pay scale basis. We have a number of different services, from high risk obstetrics to reproductive endocrinology, urogynecology, as well as general OBGYN. We also work very closely with our adolescent and pediatrics teams to provide teen pregnancy care. And we also have family planning services for both contraception and abortion care as needed. So those are all the services that we provide. And one of the things that the pandemic, for example, required us to do is to extend our services through telemedicine. So we introduced a telemedicine arm of our practice almost immediately in March, and went from 0 telemedicine visits to over 2,000. And these are visits that are provided by all providers, including our nurses for education, lactation services, antepartum and postpartum care. So another service that we provide, in regard to maternal mortality and morbidity is a 2-week telemedicine visit for all patients who are delivered out of the New York Presbyterian Cornell campus hospital. Regardless, if they are seen either privately or in our clinic, a 2-week postpartum visit by a provider, either a nurse practitioner, or one of our physicians will contact them and discuss a number of different things, including postpartum depression, lactation support, and continued care in that postpartum period, which is very important in meeting our aims for increasing our healthcare outcomes for patients who are pregnant and immediately postpartum. So that's a general overview. And then one thing I actually wanted to mention is the new Alexandra Cohen Hospital. And, Dr. Raleigh knows about this very, very well, but I know that there was mention on one of our previous calls that, I don't think that everyone was aware that there is a new hospital that just opened up in August. So even in the rush of everything that has happened this year, it was very successfully opened in the David Coe building between 68th and York. And as far as healthcare equity, all patients are seen there who deliver at New York Presbyterian, whether they're in our clinic or the faculty practice. And regardless if you can pay or not, you will get a single room where you can have privacy with your loved ones immediately postpartum. So that's one thing that, I know that is important to patients, especially after they delivered. So again, we do provide a number of different services. I do see some information also here in the chat about the Hemsley Tower that was provided. Thank you, Will, for that. And if there's any other questions, be happy to answer them.
Am I unmuted? Can I start off asking a question? How do your 2 hospitals work together? Does Health and Hospitals have a obstetrics center also? Do you see the same patients? Are you in competition with each other? How do you work together? I don't know if you both want to address it. Am I unmuted?
Yeah, we heard you. I
Okay.
can't hear Dr. Davis.
Yeah, I had to unmute myself. Yeah, no, I mean, we're different hospital systems. I think we have different patients that come to us. We take care of patients. Our primary patients are Medicaid, and some of them are uninsured as well. But that's the vast majority of our patients. And all of our hospitals do have obstetrical services. We have 11 acute hospitals. There's obstetrical services that are available at each of them as well. So I wouldn't say that we're in competition. I would say that we're different hospital systems.
Right, I would agree with that. You know, a lot of healthcare in New York City, from, you know, my personal experience, is about your geographical location. And, you know, the health and hospitals are a huge system, as well as New York Presbyterian. So, you know, competition is one thing, but I think really the focus is on how you relate with your community, what type of relationship you have with the members of your community, and, you know, how we can all work together to meet the needs of those who don't have direct contact with, you know, certain hospitals or certain services, because there are certain hospitals that may have various levels of care that they can provide to different patients.
I think that in terms of hospitals working together, I think actually New York, certainly New York City, actually New York State, that's unfair, New York State has done a better job than many other states in the US. The Safe Motherhood Initiative brings together all obstetrical units in New York City, in New York State, to work on several different initiatives to ultimately decrease maternal mortality. I think that and there has been some progress in terms of you know, decreasing the disparity. I think what is difficult and what is going to be the heaviest lift for all of the obstetrical services, and probably for all aspects of medicine, is as you were talking earlier about the social determinants, I think we're really good and getting better at taking care of women and making things safe while they're in front of us, right? So while they're on labor and delivery, while they're in the immediate postpartum stay. But if you look at the maternal deaths that have occurred in New York City, many of those deaths occur postpartum. So they're no longer right in front of us. So they've survived the delivery. That wasn't the high risk point, but they then easily get dropped off between 1 week after their delivery up until a year after their delivery. And so I think that really the challenge for obstetrics, as I see it anyway, is that we will need to partner better, and some of us partner for the first time with the community, so that there can be those bridges, and so that, as was discussed earlier, we can start way earlier. Because when we start to sort of try and change people's health during pregnancy, we have missed the first 30 years of their lives that has already impacted, you know, what's going to happen during that pregnancy. And then, you know, for all sorts of reasons, they're with us for a short period of time. And even if we do a good job with that, we haven't incorporated the rest of their lives, and then they go back to that life, right? So I think that the challenge for, as I see it, the challenge for people taking care of women is really going to be, how do we work together to take care of women long before the pregnancy, and then definitely long after the pregnancy. And, you know, all of the data shows right now that certainly, you know, I'll just give one like little example. Pregnant women that get preeclampsia or toxemia of pregnancy, which is a pregnancy only disease of high blood pressure and swelling, and can affect your kidney and your liver. But just those women who have preeclampsia during pregnancy, depending on the study, something like 5 to 12 times higher risk of cardiovascular disease as early as 10 years after having their baby. So there, pregnancy actually is probably this horrible cardiovascular stress test that, women who are already not in good shape then don't do well during pregnancy, and then they don't get the necessary care to, impact the rest of their lives. So I think that that's really, that's going to be the challenge going forward. I think we've spent a lot of time looking at the statistics, lots of time documenting the problems, but not enough time coming up with a solution. So that's where we are now.
Great, thanks. And I see Trisha, a board member, has a question.
Hi, everybody. Thank you so much, Barbara and Rebecca, for putting this together. I'm so amazed by the speakers, and thank you all for being here. So I'm really sorry, and that's my son right next to me. I'm really grateful that you're talking about this. It's something that obviously I as a young mother just went through myself, and something that is really bothering me. And I guess I have so many questions, but one in particular is I completely agree with the doctor who just said that we need to be focusing on the months leading up to and even before pregnancy and then afterwards. But if you could talk a little bit more about how we're actually expanding care for these women after in the 12 weeks after they deliver. I know that there was some talk about additional nurse visits, but I just think that there should be so much more to that. It's incredibly stressful. It's as a new first-time parent, I can attest to how just shocking it is to try to be recovering from major surgery. And I did have preeclampsia and stayed about 17 days in the hospital due to my high blood pressure after and during and after delivery. So I just really do think very firmly that we need to be doing more to expand care after in postpartum. I also was wondering about if you can speak to the implicit bias training that I hope is happening at your institutions, and who is required to take that training, how often, and if it also is inclusive of people like who work at the front desk or people who what kind of level of staff right now is required to take that implicit bias training. I just think in general, patients come into contact with so many people in the hospital that I personally don't like the idea of requiring this kind of bias training only for nurses and doctors, when I think that like everybody should recognize that there are biases ingrained in our healthcare system. So I apologize. It's probably 2 or 3 questions in there.
Thank you, Tricia.
So I can answer the last one, the bias training. We required, or I should say I, because actually it was me, I required bias training of all the providers, as you said, but all of the front desk staff, all of the nurses in the outpatient space, all the medical assistants. Essentially, I sort of took a page from what you just said and decided that everyone who was going to come into contact with a pregnant woman needed to do this training. And we did. And I think many people learned lots of things. But I think that, I'm not naive enough to think that one bias training or even one series of bias training is going to change much of anything. So I can tell you that 90% of the staff and physicians, everybody, I call everybody the staff, did the training. And we are doing the kind of training that we did was really very interesting. We have broken down into 5 different groups where we're trying to do smaller series of workshops to look at other aspects of bias and how it, reflects on patients, but also how it sort of can interfere with staff and how it interferes with our ability or inability to make a more diverse staff. So we're continuing that original training. In fact, yesterday, we, in our faculty-wide QA, which is, usually people think of quality assurance where you go over cases that, you didn't have a good outcome, and you want to review them and see how you can do things differently and not make the same mistakes that you potentially made in the past. And actually, one of the cases that I presented was a woman who had an experience, an African-American woman who had an experience recently in the hospital where she felt disrespected, and where she also felt like she wasn't being heard. I saw the patient and had a personal conversation with her, actually a couple. And I felt like it was an important case to present to the faculty and the nurses and the PAs and the residents, et cetera. Because I think that until people recognize that this really has an adverse impact on care, they won't really change their behavior. And so I think that we're going to have to just, present these over and over and over again. And I really respect what you said, how often are you doing the training? I think you can do the training, but I think how often do you review the cases and the instances and bring it to people's attention, I think is a whole different answer. And that's kind of the approach that I'm going to take. We'll see. I don't know how successful I'll be, but I think that there were a lot of people who were, several people who did the training who were still shocked at the experience the patient had. And I was like, why is this not shocking? It happens every day. But I think these are the things that we have to just bring to people's attention. And I think also, sort of making sure that patients feel empowered enough to actually make the complaint. I really appreciated that the patient made the complaint. It's helpful. We'll do better next time.
Dr. Davis, want to respond also? I don't mean to put you on.
Yeah, sure. So we've also rolled out implicit bias training, and similar to what you're saying, Dr. Riley, one training doesn't, do it, and it's continuous. So we've rolled it out, and it goes out to all staff, and now we're trying to figure out how to do different types of training that are, more smaller type of group sessions and feedback in different ways. Right now, we're also going through we're also doing, I guess, kind of like a listening tour to some extent, where we're just having what's called employee voice sessions, where we're really just listening to our employees and trying to understand, and these are in safe spaces where our employees are able to speak anonymously over the phone. They're facilitated sessions, because it's really been such a challenging environment for all of us. Our employees come from the communities that our patients live in, and we all live in the same communities. And so just having these open conversations with everything that has been happening, and, being able to talk about bias in the workplace itself, and being able to feel safe to have those conversations has been really important. And so we've just been working on creating the space for those types of conversations to happen, and for people to be forthcoming at what they might be experiencing. But I think it always goes back to treating our patients with a degree of cultural humility, and just kind of understanding our patients and being in their shoes as much as we can, so that we can really help them to to help them to really achieve what they need to achieve in terms of having good health outcomes. And that's often challenging to do, but that's what we all really strive to do. And the more that we can remember that, I think that's what makes us, better advocates and doctors and nurses. We had one of my teams, the HIV team, we hosted a stigma summit last year. And I consider myself, a doc that really tries to be empathetic and understand, my patient's perspective. And, the Stigma Summit was pretty unique because it was really put on by our patients. Like they organized it. They had some guidance from us, but it really came from them. And it was really interesting to sit and listen in that space, just to hear from them as to different situations where they felt stigmatized or unheard, just not listened to, and just terminologies that were used to describe, that they may have heard describing them. So, a term like a substance abuser, and just, how negative that term is and what that means every time they hear it, as opposed to someone who uses substances. And so really just being able to create those types of environments where we can really hear from our patients and have patients and, healthcare workers in that same room. I think it was really one of those situations where, as a doc, I completely felt I was not empowered to speak at all in that space because I did not want to say the wrong thing and offend in my just ignorance of not understanding what certain terms meant when a patient heard it. And so I think that, creating those types of environments and dialogues is really important and something that I hope that we're going to be able to continue to do.
Thank you.
You have Alita up next with her hand up.
Thank you. This is really excellent and so informative. Thank you so much, doctors, for being here. If this was addressed earlier, please accept my apologies. I've had to run in and out of this program. But I was wondering about the mental health component of healthcare, especially with pre-pregnant, pregnant, and postpartum women. I have 2 children. When my second one was born, it was a lot more difficult just in terms of sleeping, of entertaining the little one and the littler one. And I think mental health issues may have still have stigma attached to them, and the stigma may vary in different populations. So again, if you've already addressed this, I'm wondering, and then how do you, I apologize, but I'm just wondering if it is something, I think it is because you said social work, but how you address the various needs of patients and how you make that healthcare available and work with to avoid or minimize the kinds of stigma that still may be attached. Thank you.
I don't see.
Thanks.
Roger, are you on? So one thing that we, it's kind of interesting. I felt like we were kind of slow to it, but we definitely started to consistently do the Edinburgh Depression Scale, which has been recommended for the last, 2 to 3 years at least by the American College of Obstetricians and Gynecologists, that you actually give that scale at some point during pregnancy and then give it certainly 6 weeks postpartum and that really is just the tip of the iceberg, is so that you can, sort of standardly get the same information from every patient. And since I got here, I just couldn't get people to do it in a standardized way, but we finally got it up and running right before COVID. And, I think as Dr. Davis said, COVID, and certainly the mental health system that really doesn't exist was really If you think about it, you know, it was a situation where, and we still are debating, you know, is COVID worse in pregnancy? So, you know, pregnant women were scared. We thought that it was going to be like influenza, which is really bad in pregnancy, you know, no vaccine, no medications. Then there were no visitors. You know, then we went from, you know, no visitors to, you know, what my patients will tell me. In fact, a woman said to me today, she said, you know, I'm kind of excited to go home, but kind of not, because she's not going to be surrounded by family when she goes home with this newborn. And talk about the stress of that, right? So you have all the stress during pregnancy of all the unknowns about COVID, and what the impacts are on your baby, if there are any, and thankfully there haven't been. But you have all of that as well as all the other stuff, right? So am I going to have a job? Do I have food? Is my husband going to lose his job? You know, all those things. And then you go home with a screaming newborn and no help. So COVID has really kind of, you know, brought it home in terms of, you know, all the deficiencies. And so what we're setting up at the moment is, because it's so difficult to get psychiatric help in the city, for all sorts of reasons, probably because there's just not enough of it, but we're hoping to set up a system where there's a layering effect of social workers, psychologists, psychiatrists, community health workers who can, you know, help women at where they are, as opposed to where we think they may be. Because I think many women, at least my experience of having practiced OB for about 30 years now, many women have elements of postpartum depression and postpartum anxiety, but not all of the elements, and not all of them need drugs. Some of them need help in other areas, right? So it's more the situation they're in than it is the hormonal issues going on. And so we need the resources to be able to parse that out and take care of women in whatever space they're in. That's what we're working towards, is this layering system, just because thinking that you're going to have enough psychiatrists to take care of the 30% of most pregnant populations that need it, not going to happen. We just don't have those kinds of resources, or in people or money, or, you know, whatever. So I think we're going to have to be much more creative, though.
If I could just add, insurance treats mental health treatment very differently than physical health, I think, and it probably depends on the kind of insurance. And is that something that varies across the patients from H&H and the patients at a private hospital like New York Presbyterian or Weill Cornell, and how the city is able to handle those disparities in not just access, but the ability to actually get treatment? Thank you.
Access is a huge issue. I think it is across all of the state, to be honest with you. And I think it's layered on, it's multifactorial. It is the insurance issue. It is the lack of providers issue. It's, you know, sort of the pockets of the city where you can find what you need. And then there's also just knowing what you need, like someone recognizing that you need some kind of an intervention. So I think this is an area that I think all of us have a lot of work.
Will Dr. Davis respond also?
Yeah, sure. Yeah, I mean, I would agree with everything that you're saying. One of the things that we do, we do a lot of mental health care within our primary care settings. And what we've done is developed a collaborative model through our, where we have consulting psychiatrists who then work with our social workers, some of whom come through the Mental Health Service Corps, which was the Thrive NYC program. But so we have the consulting psychiatrists who work with the social workers, and even some of our nurses, where we have educated on how to do some counseling, and depending on how impacted that patient might be in terms of their mental health, sometimes that's enough that they see a social worker, or they might see what we call a collaborative care nurse, under supervision by a psychiatrist. This allows the psychiatrist to be able to take care of many more patients because they will have then like weekly case conferences where they discuss all of the patients. So it allows that one psychiatrist to have a much larger reach in terms of the amount of patients that they can consult on, as opposed to the psychiatrist that's trying to see patients one-on-one. So those are some of the ways that we're trying to expand the reach of our mental health services. We do screen our patients for depression and also anxiety, as well as we're screening our adolescents and we're screening in our women's health clinic. So we do proactively screen our patients for depression, and we're anticipating that the needs are going to go up even more. COVID has traumatized New York City. I don't know if you guys feel traumatized. If you haven't lost someone, you know someone that has lost someone. I don't know anyone that's lived in New York City during this time that has not been impacted by COVID in some way. And I think for our patients with limited resources, they're impacted even more because they're living in the communities that had extremely high rates, where they saw lots of death, where they've lost lots of loved ones. And I think we're going to be going through a long period of post-traumatic stress disorder. So I think we have to screen our patients. We have to screen them more aggressively now for mental health. If there's, just lots of financial issues, like you said, do I still have a job? I don't have a job. We're seeing, food insecurity is, the rates of food insecurity is so high. People who've never depended on any social services are now depending on social services. So I think it's going to be a lot for us to manage as healthcare systems, and we work to try to manage it and to expand our resources as much as possible by doing these layers of care and using our psychiatrists as consultants in some ways. But I think this is a need that unfortunately I think there's going to be a gap, and that gap is probably going to widen because as months come, in the coming months, I would expect that there's just going to be lots more mental health needs.
Right. And can you hear me? I was thinking
Sure.
before.
Yeah.
One thing, what both Dr. Riley and Davis mentioned, is the multi-layer and really the need to collaborate with a number of different providers, not just physicians. So at the HT5 clinic, we'll be starting group prenatal support classes, which is actually a new program that our social workers have initiated because of the results of the devastation from COVID. So that is, it sort of addresses the shortage of providers, but it provides a ability for access, and we can do that virtually. So I think, as far for our patient population, telemedicine has been at least somewhat helpful in bridging that gap for access.
Mm-hmm. Right. Thank you.
Thank you. I see Ellen has a question.
Hi, everybody. So this is really interesting. I have a few questions for both institutions, all three of the doctors in both institutions. So to expand your reach in well, do you use midwives for postpartum and prenatal care?
At Weill Cornell, unfortunately, we don't. Okay. I'm not happy about that. I'm working on it. Actually, we are hiring a midwife in January, so that'll be great. I actually am a huge fan of a doula program. I am convinced, I don't know, I worked with a great doula program in Boston, and I'm convinced that a doula program could be incredibly helpful for a wider population and the thing I like about the doula program is that there can be many more of them because they're in the community, as opposed to midwives, which, you know, that's a few years of training and training up that many. That's not gonna, we're not gonna get to the numbers we need quite quickly. But I do think that there's a lot of benefits to a doula program. So that's what I'm working on.
We do use midwives at health and hospitals. I don't know if all of our hospitals have them, but we definitely do use midwives there.
So you really use whatever groups you can to other professionals to expand your reach, as you said before. That's great.
Definitely.
Okay. All right. So my second question. This is actually a very unfortunate circumstance that happened to a friend of mine. She went for a mammogram, and the result of the mammogram was that she needed a biopsy, except that the doctor didn't tell her she needed a biopsy. So she went another whole year, probably a year and a half before she got another mammogram, and found out that she had needed a biopsy the time before. So by the time she had this biopsy, her cancer had progressed to the next stage, and it was more, and she required additional treatments and more extreme treatments. It was very unfortunate. She's still going through it. So I would like to know what protocols your hospitals have in place that avoid this from happening. Do you have checklists? Do you have, you know, do you have other people? Well, let me let you talk.
You know, in the clinic, what we all results are reviewed by our nurses. So we have registered nurses who review all results, and abnormals are addressed by the providers with either a phone call, a visit appointment, or telemedicine visit. So I think at least we have that one layer of checks, and even when we're having supervision for trainees, attendings, physicians are the ones who also receive and check all of those results. You know, I'm not, I would be remiss to say that it's a perfect system, but you know, by at least having that multi-layer of checks, we, you know, hopefully can avoid those type of unfortunate things that, you know, you experienced.
Yeah, similarly, for us, I don't know if it's the same procedure at every single hospital. I can speak for the one that I've seen patients in within health and hospitals, and there's similar structures in place, but it really is having multiple levels so that if there's an abnormal, for our hospital, the radiologist would report, actually the radiology technician would report that abnormal, and would relentlessly contact you until they have had confirmation from a doctor that said, yes, I have seen and have placed the order for whatever that follow-up test is. You know, these are some of the biggest fears in medicine, is to kind of miss something and for something to progress without, you know, because someone did not, you know, follow through on a result, or, you know. So I think we try to put in processes that are not dependent on any one person, so that there's some redundancy in these processes to try to prevent these types of things from happening. Because anytime it happens, you know, the one time it happens, it's one time too many, and you definitely want to try to prevent that. So we have some redundant processes to prevent that from happening.
So you said that the radiologist relentlessly pursues whom?
The radiology technician actually relentlessly pursues the physician to make sure that they've seen they've seen the abnormal, and they've ordered whatever follow-up needs to happen. So there's some there's some things that are a little automatic through the electronic medical record system, but if they haven't seen the order, then they would, pursue and say, hey, doc, how come you didn't write that order? Let's make sure that it's written so that the patient can come back.
I see. So it's not possible for a physician to just blow it off, to say, yes, I know about that, and then not write the order. So they actually follow up and make sure the physician.
Yeah, they try to put in systems so that it would trigger if that patient, didn't get that appointment. That's how they would try to, that's how we try to do it. At least at the hospital that I was seeing patients at, they were pretty relentless in their pursuit.
Okay. And do they follow up to make sure that the order was actually got to the patient?
Yeah, because if the patient actually doesn't show up, then, then that's a problem. So even if you've written the order and then a patient missed the order, this is, sometimes right, where the challenge is. They miss the order and then there isn't that follow through. So yeah, they try to create the systems, or we try to have systems so that even if the patient missed that appointment, we would say, oh no, like this isn't just one of those appointments we want them to miss, right? Or we can deal with them missing. We want to make sure we get them in because this could be something serious.
Okay, great, thank you. Now I have one more thing, this is my pet peeve. And this doesn't have to do with OBGYN, it has to do with just general medicine, that older adults who very often come in sick and have some sort of delirium are treated as, and I've seen this across the board in many hospitals, are treated as if they have dementia. And so they're kind of dismissed. And then serious illnesses are not necessarily taken into consideration because, if the blood tests all check out and then, and they're still acting nuts, people are not, the medical staff is not treating them as if they have a real delirium or potentially another serious illness. They're just dismissed as if they have Alzheimer's. It's just like another demented adult, older adult. It just infuriates me. So I just want to put that out there. I don't know, I don't know if OBGYN is the place to address it, but I just want to bring it up. And I will bring it up continuously.
Well, I think what you bring up, though, actually is that, and I think that there's plenty of studies that would support this statement, is that it is another area of bias, right? So, you make assumptions about people when you walk in the room, and people make assumptions about the patient looks old and they're not acting quite right. The next assumption is, well, must be dementia. I mean, it's a form of bias, right? Without stopping to do the investigation, to ask more questions, and to, make a better diagnosis. So I think, I don't know that it's necessarily GYN, but I think that it is, yet another one of the things that we just have to be aware of, which happens in medicine all the time, unfortunately.
Right. Thank you.
Thanks. I see next we have Betty Cooper-Wallerstein. And is it *6 to unmute or *9, Will?
*6.
On the phone. *6.
So Betty, hit *6 and we'll be able to hear you.
Hi, thank you so much. It's been an excellent discussion. I am a donor as well as a patient to the medical department of New York Presbyterian and Weill Cornell as well. And I'm interested in knowing about the new Cohen Hospital in the Koch building. You spoke a little bit about it opening up this past August. How much of the hospital, because there are several divisions there, how much is available for the patients that you discussed who would have single room? For where you were talking mostly about GYN and people, having babies, etc. But can you tell me a little bit more about what is available there, and is it available for everyone or just for people from that hospital?
So the Alexandra Cohen Hospital for Women and Newborns is the top 5 floors of the David Koch building. The 12th floor is all of ultrasound, obstetric and GYN ultrasound and antepartum testing. The 14th floor is an expanded labor and delivery. The previous labor and delivery had about 11 rooms, and this is 16 rooms. It also has about 20 triage bays and 5 operating rooms, so it's quite a huge space. It has the capacity for about 7,000 deliveries, and currently we do about 5,300 deliveries a year.
So are these patients only for the hospital, or do you take patients from, for example, would someone from a city hospital who might be having some concerns and some difficulties and questions about delivery, do you also take patients that are not hospital patients but might be city hospital patient referred?
We take any patient who shows up in labor. We don't turn anybody away. But in general, I think most obstetrical services want to take care of the people who have gotten their prenatal care in our institution, whether it's in the HT5 clinic or it's in one of the faculty practices. That's the bulk of our deliveries. So, but there are women who, were getting their care at Montefiore or one of the city hospitals, and they hear about a shiny new hospital, and so they show up and they deliver. And hopefully they have a really good experience. But that's, that is because, there is, I don't believe that there's any hospital that can turn you away when you're in labor. That's an EMTALA violation. That just is cruel and unusual. But the hospital is all women and children's, and so it's all labor and delivery. And then there's a neonatal intensive care unit, which is really quite expanded. So that's now a 60-bed NICU, and then 75 single postpartum beds. So there's no GYN there either. GYN is in this original space that it's been in.
Thank you very much. I was very interested in all that you were saying. I had another question, though. The city hospitals that are, I think there's only one in the district of CB8, but in Manhattan, how many city hospitals are there?
Let's see, I think 3. We have Metropolitan, Harlem, and Bellevue.
Well, Metropolitan, I know. Where is the Harlem Hospital?
It's in Harlem at about 135th Street, I believe, and Adam Clayton Powell, somewhere around there. And Bellevue is downtown Manhattan, around 30th Street and First Avenue.
Thank you so much.
You're welcome.
Next, I see Dawn.
Hi, thank you so much. I really appreciate this webinar and the opportunity to hear all of this great information. I have 2 questions, please. The first one is, I'm aware that prior to the pandemic, there has been a challenge with poor providers with knowing where to refer women who are experiencing maternal depression for treatment. So screening is one thing, but then I've spoken with a lot of providers who said, we don't know where to refer. So I'm just curious how how that's gone during the pandemic, and has telemedicine made a difference with that at all?
We heavily utilize telemedicine psychiatric services during COVID. We utilized them for the staff that definitely needed it. And we also utilized it for patients. And we actually had more psychiatric help during COVID than we had before or after COVID. It's like starting to go away. I think part of it was the psychiatrists, were easily able to go in to use the telehealth platform. So they really sort of rolled up their sleeves and started helping everyone. So we actually had a very good experience. But again, now that the immediate part of COVID is winding down, I think that, we're in the same situation that Dr. Davis mentioned, which is, you really do need to layer your resources because, there's never going to be enough psychiatrists or psychologists. So we need to, take advantage of the fact that there are social workers and nurses who can, help, triage patients, and primary care physicians, and actually obstetricians as well. There's nothing wrong with me picking up the phone as an obstetrician to ask a psychiatrist, do you think I should start X medication? I mean, I think it's a matter of being sure we all feel trained and comfortable and have those resources. But again, psychiatric help in the whole US is terribly underfunded and under-resourced.
Thank you.
And I know Dr. McDougall has to sign off soon, so I just want to make sure, I don't know if you have any closing words or anything you want to say before you have to leave it.
No, thank you for this opportunity. I think I just started recently actually with Cornell NYP in January, and immediately after that it was COVID, so I haven't really had an opportunity to do the community outreach and meet some of the members of the Upper East Side. So it's great to have this opportunity to speak. I'm happy to join in future events that you may have. Please reach out to a number of people. I know Anna Garcia is also here who may be able to provide more information. Thank you, Will, for providing the information about Hemsley Tower. But please, if you have any other questions or you'd like to reach out to a community, an underserved population that's right in your neighborhood where you live, find out how you may be able to get involved and contribute. Thank you.
Dr. Davis, did you want to respond also?
I'm sorry?
Did you want to respond to Dawn's issue at all? I saw you shaking your head, yes. So I think I'm in total agreement with everything. Can I just say to thank you, Dawn, for coming. Dawn is one of Liz Kruger's wonderful staff, and I've worked with Dawn over the time. So it was good hearing from you, Dawn.
Oh, my pleasure. And may I ask one other question, please?
Sure.
Okay, great. So this is related to telemedicine as well, or more specifically to telemedicine. So Senator Kruger has, just questions about what might the potential be for telemedicine to create a two-tier system of sorts. So in other words, whether some people would have greater access to in-person medical appointments or even to telemedicine. And I guess there could be advantages to either depending on the circumstances. So I don't know if you have thoughts about that at this point.
Yeah, I mean, we've definitely pivoted a lot towards telemedicine, and that is definitely one of the things that we have to be really concerned about, is not creating another level of inequity through telemedicine services. We have telephone visits, which, most of our patients have access a cell phone. So so that really isn't the issue. However, not everyone has access to unlimited minutes on a cell phone, and they may not want to use those minutes to talk to their doctor. So I mean, so I think, you know, we have to always think about that. Video visits, you know, we're also utilizing video visits, but not everyone has not everyone has a computer that they can access the system through, because most people really utilize their phone as their source of internet, and they may not all work through the cell phone app, and you might need, you know, the computer or a tablet. So I mean, I think we have to be careful with the technologies that we embrace, that we're not creating any type of system where some people are accessible to it, you know, or have access and not. And then there, you know, in addition to just having access, you have to think about the digital literacy of some people, right? So some folks are not as comfortable using video devices or telephone to access their medical care. And how do we serve them just as well as people that are more comfortable? So I think telemedicine in some ways has made things, you know, more accessible. And absolutely during COVID, you know, we had to pivot towards that. We were leaning towards doing a lot more telemedicine anyway. COVID completely accelerated that. But we also have to keep in mind that it could be creating some inequities. And this is something that we'll be looking at very closely to make sure that the same level of care, that we're able to deliver that same degree of care. For example, someone that has diabetes, we can do a lot of things through telemedicine. They can send us their blood glucoses. They can, you know, sometimes upload it through through their glucometer. It can come into our EMR. There are a lot of things that it can do, but it's not for the same for each patient. And so we still have to figure out how to meet patients exactly where they are so that they have, you know, the right tool that can help us to take the best care of them.
And I imagine that insurance and reimbursement rates play a role as well. I'm just guessing.
Yeah, so insurance and reimbursements is definitely something that we take into consideration. The reimbursement for things like video visits are pretty much the same as in-person visits, whereas for a telephone visit, it's not the same. So you have less reimbursement when it's just a telephone visit. So of course, you know, we would want to be doing more video visits, but what's most important is that our patients are getting some care. Some of the technologies are not paid for by insurance. For example, you know, glucometers, or only paid for by insurance, glucometers that might upload a blood glucose result directly to our system. That's not going to be accessible to our patients without insurance. It will be accessible to those who have insurers that will cover it.
Thank you so much. I really appreciate it.
You're welcome.
Thanks. Next, I see Meryl.
Hello. It was a great and interesting webinar. Just any thoughts on how a pandemic vaccine might be distributed to children and mothers who are on welfare and who are in circumstances that would otherwise result in them not receiving the vaccine? Is, you know, it seems to me that they're so eager to get it out there, but that there's going to be a lot of problems in distribution. And clinics such as you described it at Weill Cornell certainly have ample opportunity to reach out, as do all the municipal hospitals. Any just general thoughts on how we might get a vaccine to all these people who so need it?
So I think the vaccine story is just, it's a toughie, right? I think that, you know, there's one part of it is, you know, will the vaccine be safe for all of the people who need the vaccine? That's one major question. Will the vaccine be efficacious? that's a whole nother question. I'm going to say, yes, the vaccine's efficacious. Will we have tested enough of the population to feel comfortable that it's safe in all of those populations? So I'm a huge vaccine advocate, but I'm also a huge women's health advocate. And it worries me to death that pregnant women aren't included in late phase 3 trials. So when the vaccine is available, it's going to be very difficult for me to have conversations with my patients about whether or not to recommend the vaccine during pregnancy. And I feel like it's possible that we may not recommend the vaccine for all pregnant women, but certainly the data would suggest that pregnant women with diabetes and obesity, and some of those with hypertension, are at significantly increased risk for severe outcomes related to COVID-19, in which case you might want to think about them. Or healthcare workers, right? Frontline. I think that the next piece of that is, it's all about the safety and obviously efficacy, but it's also about patients' acceptance of the vaccine. So the very populations that may actually need the vaccine the most are also populations that historically have not been excited about any vaccine. And a vaccine that, is being pushed by Operation Warp Speed ain't making people feel more comfortable. So I think it will be interesting to see how it all plays out. I think that, I'm actually on the CDC's work group on COVID-19.
Oh, that's good.
So I think
have
about
great
this,
people on those task force.
I know, and I think about this all the time, but those are all the things that we need to be worried about. Just having the vaccine is not really the issue. It's people being immunized that's going to change our lives. So how we go from a vaccine available to people actually being immunized, as you said, is really complex.
That's my problem. As somebody who would be, like somebody in the public officials are confronted with this issue of distribution, immunization, as you put it so clearly. And I don't think they really have a plan, but I think they're going to get one real fast because it's the nature of this pandemic to do everything too fast. So we'll see just as you suggest, this will be very interesting, but let's hope it's not full of pitfalls and that we get this thing moving and that in fact it kind of ameliorates some of the inequities in the system as it stands, because it's the first test that the government's really had to do something useful to stop inequities in public health care. Anyway.
I'd like to hear from Dr. Davis about what effect it would have the public hospitals. Will the vaccine?
Yeah, I mean, I think it's such a charged question. I think the question about distribution is probably the least of the parts of the equation, because I the vaccine will get to the hospitals. Let's say we have this amazing vaccine that works and it's efficacious and everyone is convinced that, this is great, no problem. Highly optimistic. But if we're in that space, those vaccines will get to the hospitals, and the vaccines will then get to the patients, or they will have the opportunity to get that vaccine, similar to how we do massive vaccination with flu, right? The question then becomes whether or not people are accepting of that vaccine. We are unable to vaccinate everyone for flu because there's lots of, for various reasons, but there's also distrust in the flu shot. Does it work? I think we're going to see that. I think that that's just going to be taken even more to the extreme with a vaccine for COVID because of everything and all of the conversations that have been happening around that vaccine to date, and just having so many mixed messages about it. You hear about one trial stopping, then it's restarting. So I think, you know, for people that are just kind of hearing the one-liners and seeing the snippets that go across the TV screen every morning, this is really confusing, right? And so when there is a vaccine and it is available, and eventually there will be one, maybe not at the time frame, you know, that our federal government would want to say, but eventually there will be one. But there's been already so much confused messages around it that by the time I think we get one, I think we will have to spend so much time trying to change the conversation and to change what people have already thought about it, because there's going to be so many preconceived thoughts, and people would have already made their decision up, I think, as to whether or not they're going to take the vaccine or not. I think people are already making the decision as to whether or not they're going to take a vaccine when it becomes available. And I think, to your point, Dr. Riley, like, we have to have it tested in all of the populations that should be getting the vaccine. We can't give the vaccine to the elderly who we know are at really high risk of having bad outcomes with COVID if they haven't been into clinical trials. And many people in the trials are, you know, young, healthy patients. This particular trial that's enrolling 30,000 should have a wider spectrum of folks, but the initial trials have been young and healthy individuals. And so I think we still have a long way to go, but when the vaccine is available, you know, my understanding is that the strategies will be to get it to those people that are at the highest risk of having COVID and having adverse outcomes with COVID.
Thank you.
Thank you.
Next, I see Alita.
Thank you. Whoops. Thank you. The sign says I'm muted and unmuted at the same time. So, but anyway, if we could go back to pregnancy for a minute, I just wanted to ask you about breastfeeding, because that's something that, from everything I understand, could have a lifelong positive effect on babies as they grow into children, as they reach adulthood. And is there a different impact? Is there a different desire to breastfeed babies among different populations, and how do both doctors from both hospitals address that and urge, if you do, women to breastfeed their babies? And then how you also ensure that what they're ingesting themselves, the vitamins and nutrients, are sufficient, because so many more calories are needed. So I'm just curious about this, and thank you.
It's a national priority for to breastfeed children up until the age of 1, if that's possible. And it's a priority for a couple reasons. One, because as you said, it looks like children have better outcomes. Certainly in the first few months of life, they have lower risks and rates of infection just from maternal antibodies. So I think, you know, that's just one of many reasons to breastfeed. I think also, which we don't talk about that much, but it's important, is for a lot of women, it's a good idea to breastfeed because it does help with losing weight postpartum. And for those women who, you know, have issues with sort of being unable to get back to their pre-pregnancy weight, that then just, you know, leads to more problems later. It becomes, you know, even more important for them to breastfeed and in their best interests, actually. You know, I think that a lot of, I would say probably every single obstetrical unit in this city, if not in the state, has a huge sort of group of people who do lactation support. There's a lot of lactation support in the hospital, but again, as I mentioned, there's a lot of things we can do in the hospital that then just can't get carried on outside of the hospital. You know, we're trying to do virtual lactation support. We started that with COVID. It's been done elsewhere, just we weren't set up to do it. And so we're doing it now. And you know, it works to some extent, but again, I'm more interested in the doula program because I think that they're much better at it, to be honest with you, and they're in the community. And also they have a better understanding of sort of what some of the community preferences are, because, you know, every racial and ethnic group has a different feeling about breastfeeding and a different idea. And so sometimes I find the nurses are all, you know, you must breastfeed like 25 times a day. I'm like, really? No, I don't need to do that. I can breast and bottle feed because that's what my West Indian parents told me. So I think that there's, you know, some benefits to opening that line of communication up a little bit more.
And I think we just have 2 more questions, but I know Dr. Riley, you said you had to leave, I think.
Yes.
And I just want to thank you so much for your surprise joining our call. We can't thank you enough for participating, and we hope to work with you again soon.
My pleasure. Happy to come back. And Dr. Davis, what a pleasure to meet you.
Nice to meet you as well.
Can I ask one last question of Dr. Davis that I think is important? I know that there's Health and Hospitals has 11 hospitals and a large number of community hospitals. I don't know what they're called. What are they? How do they affect health? Can you explain a little bit about what the community outreach, are they called community hospitals or?
No, they're not hospitals. They're community practices. So they're like various clinics that are throughout New York City.
I see. So instead of going to the hospital to a doctor, you would go to one in the community near, you know, a community area. I see. And then if you need to be hospitalized, you would go to one of the 11 hospitals.
I'm sorry?
If you need to be hospitalized, that's when you would go to one of the 11 hospitals along the way. Okay.
Yeah. The community sites are all ambulatory care centers. So they're your primary care clinics, your GYN care, your pediatrics care, all of your outpatient regular medical care. And then at our 11 acute hospitals, they all also do have an outpatient part, you know, so you do have an outpatient clinic there as well, but the 70 are throughout New York City in our community settings.
That's great. Thank you. Okay, Rebecca, is there any more or should we
I don't see any more, but
this has been, thank you so much for everybody that's left. I think this is so interesting and so helpful. Just want to say that Rebecca and I and our whole committee have identified 2 more of these Zoom meetings that we're going to have. One will talk about mental health, specifically with senior issues during this part and after. And the third one, I think, will be more of an overall discussion about, more of a high level of what else needs to be done and what have we learned and what have we learned in the past with AIDS and so on that we're working on. So stay tuned, everybody, and thank you again, Dr. Davis, all of you that have been.
It's a pleasure. Thank you.
I just want to thank Dr. Davis, Dr. McDougall, Dr. Riley, Anna, Andrea, Nicole, and Will, of course. And I see we have one hand up, so maybe we can let Billy have a quick statement before we have to go. But Dr. Davis, and thank you so much for sticking around with us for so long. We really appreciate it.
No worries. Thank you.
Yeah, I'll keep it super short and hopefully it's worth it. But I just wanted to commend Barbara and Rebecca for putting this together and the panelists. This is one of the most informative community board meetings I've been to in a long time. So thank you all. I really learned a lot. This was terrific.
Thank you. Thank you. This was wonderful. And I'm just so pleased with everybody. Thank you. All right, I guess that's good night. And good night. And thank you, Will, as always.
Happy to be here. Happy to help. If you have any of your friends who missed today, the video is going to be on our website. So just have them check it out on YouTube.
Great. So good night, everybody.
Good night. Thank you.